Hello, I'm Manjit Matharu. I'm a professor of neurology at University College London, Queen's Institute of Neurology, and a consultant neurologist at the National Hospital for Neurology and Neurosurgery in London. I would like to start by thanking the Ehlers-Danlos Society for kindly inviting me to give this lecture on fatigue and headache disorders. This is my disclosure slide. Before we discuss fatigue and headache disorders, let's take a moment to look at the definition of fatigue. Outlined on this slide is the definition of fatigue provided by the ICD-11 document. The key aspects of this definition are that fatigue is a subjective feeling of lack of energy and increased sense of effort. It leads to reduced efficiency and ability to accomplish mental and physical activities. It can be acute or chronic. Acute fatigue is common, and all of us will experience it at some point. It resolves with rest. In contrast, chronic fatigue persists over time, is constant or is recurring. It is not relieved by rest and interferes with usual activities and function. This definition of fatigue provides a standardized framework for considering this symptom. Let's now turn our attention to headache disorders. There are a very large number of headache syndromes described in the literature, well in excess of 200 different types. The vast majority of these headache disorders are secondary headaches. However, what is of interest to us today is the primary headaches. The International Classification for Headache Disorders subdivides the primary headaches into four main groups. Migraine and tension type headache represent the vast bulk of what is seen in clinical practice, well in excess of 95% of the patients we will come across. A third grouping is the trigeminal autonomic epiphalgias, of which the prototype is cluster headache. And the fourth grouping is a miscellaneous group of primary headaches that is listed on this slide. Both the trigeminal autonomic epiphalgias and all the other primary headache syndromes are relatively rare. Now, which of these syndromes are associated with fatigue? Most headache specialists and general neurologists will tell you that almost all primary headaches are associated with fatigue. However, there's a paucity of research in this area, and when we go through the literature, the primary headaches that have been reported as being associated with fatigue include migraine, tension type headache, and cluster headache. Now, having covered the headache syndromes that are associated with fatigue, let us now look at what evidence we have for the prevalence of fatigue in these headache disorders. Let's start with migraine. For migraine, there are 5 studies that have looked at this issue in detail. The first study looked at patients with both episodic migraine and chronic migraine, and most of these studies have used the fatigue severity scale. It reported that almost 60% of the patients with episodic and chronic migraine had significant fatigue, pathological fatigue. The second study was by Kumar, who looked at 30 patients with episodic migraine and 30 with chronic migraine. They reported that when you look at pathological fatigue, where the fatigue severity scale score is more than 52, then in chronic migraine, this occurred in 60% of the patients, and in episodic migraine in 20% of the patients. A different scale called the Chalder scale, in fact, in the same population, came up with higher figures of 83% and 63% for chronic migraine and episodic migraine, respectively. A third study looking at the episodic migraine population and comparing it to the healthy controls reported that in episodic migraine, there was pathological fatigue in 41% compared to 11% of healthy controls. And another study looking just at chronic migraine reported that 84% of the patients had pathological fatigue. There was also a study just comparing episodic migraine versus chronic migraine, which reported that there was more fatigue in patients with chronic migraine than in episodic migraine. And in essence, the overall message is that approximately 60% of the patients with migraine are going to report fatigue, and fatigue is much higher in chronic migraine patients, approximately 80% of them, as opposed to episodic migraine, in which case it's 40 to 65% of the patients. Some of these studies also looked at the presence of chronic fatigue syndrome as defined by the CDC criteria. And one study reported that 23 0.3% of the patients with chronic migraine had diagnostic criteria of chronic fatigue syndrome fulfilled, and in episodic migraine, that figure was 13.3%. Another study, the Paris study, reported that figure was in fact a lot higher, almost 67% of the patients. If we then look at cluster headache, then a study by Snore, which looked at 500 attacks in 57 cluster headache patients, reported that in the pre-ictal phase, 5.6% of the patients reported fatigue. But when you looked at reduced energy levels, then almost 13% of the patients also reported that. This is even prior to the attack coming on. During the attack, those figures were 20% and 30% respectively for fatigue and reduced energy levels. And in the post-ictal phase, almost 40% of the patients reported these symptoms. Now, we can look at the whole thing by looking at patients who've got chronic fatigue syndrome and finding out what is the prevalence of primary headache disorders. This has been done by Ravindran et al. And they looked at a cohort of 203 patients with chronic fatigue syndrome and compared them to healthy control population of 368 patients. They reported that in the healthy control population, approximately 5% of them had migraine, which is much lower than the 15% we would expect to see in most healthy controls. The figure for attention type headache is approximately what would be expected, about 40%. But what's interesting in this data is that when you look at this data for chronic fatigue syndrome, you find that 84% of these patients had migraine and 81% had chronic tension type headache. This issue has also been looked at in a large registry study in Taiwan, where they interrogated a nationwide population-based database. They identified almost 7,000 migraine cases and 27,000 migraine-free cases. They went and then looked for the prevalence of chronic fatigue syndrome. And they reported that the chronic fatigue syndrome had a 1.5-fold higher chance of occurring in the migraine cohort. So, what are the factors that could contribute to fatigue in headache disorders? So, it's very clear that the headache disorder itself, with the pathophysiological processes mediating pain and discomfort of the headaches, can lead to fatigue. And I'll provide you with some more data later on. But the other factor to take into account is the medications that are used. Very many of the medications that are used to treat headache disorders, in fact, can cause fatigue. So acute treatments such as the opioids and the triptans are very well known to cause fatigue. But also the preventive treatments that are used, such as the beta blockers and tricyclic antidepressants, can also lead to fatigue. And not only fatigue, but you can also get mood disorders with some of these treatments. So treatments such as topiramate and flunarizine that are commonly used in the treatment of headache disorders can have a mood disorder as a side effect. And we know that mood disorders are highly comorbid with migraine, but mood disorders themselves can also cause fatigue. So you can have medications causing a mood disorder, which can then in turn lead to fatigue. With some of the headache disorders, such as cluster headaches, the attacks tend to occur at night, with patients waking up multiple times, and that can lead to poor sleep quality and then in turn lead to fatigue. And there's also lifestyle factors that tend to kick in. So patients with chronic migraine, for example, will find that they have motion sensitivity and will spend a lot of time being physically inactive. And this can then lead to deconditioning, which can further perpetuate any fatigue that they have. And add to the mix that we have a coexisting health conditions such as chronic fatigue syndrome and fibromyalgia that are far more common in migraine than in the healthy control population. And this in turn will mean that there'll be more of a propensity for these patients to have fatigue. So headache-related fatigue is a multifactorial problem related to the attack itself, to the treatments of the attacks, to the lifestyle factors that are often forced upon the patient by the condition itself and by the comorbid conditions. So there's evidence for fatigue in a significant proportion of patients with headache disorders. However, does this fatigue have any impact on the headache sufferers? There's emerging evidence that patients who have headache disorders and fatigue as well are highly disabled, and have a poorer quality of life. This study by Kumar et al. In 60 migraine patients, which reported that fatigue occurred in 60% of the patients with chronic migraine, 20% of the patients with episodic migraine, also looked at the headache impact test scores. The headache impact test is a disability score secondary to headache disorders. And they noted that the headache impact test, the HIT6 score, was significantly higher in patients with migraine who had fatigue compared to those who did not have fatigue. Similarly, they noted that those who had chronic fatigue syndrome had much higher scores than those who did not have chronic fatigue syndrome. An additional finding was that fibromyalgia, depression, anxiety, and sleep disorders were significantly higher in the chronic fatigue syndrome group. In essence, routine daily activities ranging from either household chores to recreational pursuits can become challenging due to fatigue and headaches. Over time, this can lead to significant reduction in the quality of life, with patients often expressing feelings of helplessness or frustration. Which then leads to the issue of mood disorders. So, Perez et al., in their study on 63 patients with chronic migraine, noted that 84% of these patients had fatigue. They went on to exploring the relationship between depression, anxiety, and fatigue, and noted that there was a strong correlation between depression and anxiety compared to fatigue, both physical and mental fatigue. So, fatigue and headache disorders can amplify feelings of anxiety and depression, and the persistent nature of fatigue coupled with the pain of headaches can lead to a negative emotional cycle, impacting a patient's overall mental well-being. This then leads to the cognitive impairment that very many of these patients report. Fatigue leads to cognitive impairments such as reduced concentration, memory lapses, and decision-making difficulties. For headache sufferers, this additional cognitive burden can exacerbate the already debilitating effects of headaches, further impairing the daily functioning. Sleep is also impacted on significantly, as I've outlined already before. But what's the evidence we have for this? So Kumar et al. In their study of 60 migraine patients also looked at the excessive daytime sleepiness scores. And they reported that borderline to excessive daytime sleepiness scores were found in 73% of the patients with chronic migraine and 40% of the patients with episodic migraine. The Epworth sleepiness scale scores were also significantly higher in patients who had migraine with fatigue or migraine and chronic fatigue syndrome as compared to those without these syndromes. So fatigue and headache can disrupt sleep patterns. Patients may experience difficulty falling asleep. They have frequent awakenings or non-restorative sleep. This disrupted sleep can further exacerbate fatigue, creating a vicious cycle for these patients. This in turn has an impact on occupation and social life. Fatigue coupled with the headaches can lead to decreased productivity, increased absenteeism, and even job losses. Social interactions can become strained, and patients may withdraw from social engagements, miss events, or avoid making plans altogether, leading to further feelings of isolation and emotional distress. So, what do we know about the pathophysiology of fatigue and headache disorders? This is poorly studied and understood. However, there are several mechanisms that have been proposed. The first mechanism to consider is that of the cellular structures that are involved in both fatigue and pain. Approaching this from the migraine perspective, migraine is best considered a neural disorder of brain function in which there are alterations in the aminergic networks integrating the limbic system with the sensory and the homeostatic systems. Functional imaging studies in migraine and other headache disorders report the activation of a wide network, including some of the structures shown in this figure. These brain structures overlap with the structures that are involved in the mediation of fatigue. The structures shown in red are the ones that have been reported to be involved in fatigue. Hence, the association of fatigue with migraine in particular, but headache disorders in general, may be due to a shared neurobiology and transmitter systems. With regard to neurotransmitter systems, You will notice that the aminergic transmitters such as dopamine, serotonin, and noradrenaline turn up in various of these structures, hence suggesting that they may play a critical role in the mediation of both headaches and fatigue. Besides dysregulation of the aminergic neurotransmitters, there's also the possibility of the involvement of the inflammatory mediators. Pro-inflammatory cytokines such as interleukin-1, interleukin-6, and tumor necrosis factor have all been implicated in both headache disorders and fatigue. It is well known that elevated cytokine levels can induce fatigue-like behavior, which has also been reported in patients with migraine, thereby suggesting an overlap in the inflammatory pathways. Another important pathophysiological mechanism to consider is mitochondrial dysfunction. It has long been known that there is mitochondrial dysfunction in patients with migraine. This leads to an imbalance between energy supply and demand, thereby contributing to migraine susceptibility. Mitochondrial dysfunction has also been observed in neuroinflammatory, neurodegenerative, and autoimmune disorders, as well as patients with idiopathic fatigue. So it may be that the common underlying factor that leads to both headache disorders and fatigue is mitochondrial dysfunction. Another important consideration is sleep disturbance. We know that sleep disturbance is common in headache disorders. Disrupted or non-restorative sleep can lead to increased fatigue, forming a cyclical relationship where fatigue exacerbates headaches and headaches in turn exacerbate fatigue. An important consideration here is the glymphatic system. The glymphatic system clears the waste products from the brain during sleep. One hypothesis is that disrupted sleep in headache disorders leads to accumulation of waste products, which then makes the patients prone to both fatigue and headache disorders. Another consideration is the hypothalamic pituitary adrenal axis. We know that chronic stress can lead to dysregulation of this axis, affecting cortisol release, and this may then contribute to symptoms of fatigue. It is also worth remembering that the hypothalamus becomes abnormally activated in syndromes such as migraine and cluster headaches, which may in turn potentially dysregulate this hypothalamic pituitary adrenal axis. A final consideration is the autonomic nervous system dysregulation. It is known that there are imbalances in the sympathetic and the parasympathetic system in both headache disorders and fatigue, and this may be a common link between the two. Conditions like fibromyalgia, chronic fatigue syndrome, and mood disorders, which have fatigue as a symptom, often overlap with headache disorders. This suggests that there's shared pathophysiological mechanism between these conditions and the headache-induced fatigue. Let us now consider assessment of fatigue in headache disorders. What are the considerations one needs to have in mind when assessing these patients? Fatigue in the context of headache disorders can be quite nuanced. It's pivotal to differentiate it from other related symptoms such as drowsiness, weakness, or even malaise. Clinicians should be vigilant for red flags that might indicate secondary causes for headache, such as tumors or infections, which might also contribute to fatigue. In my clinical practice, I use clinical scales like the fatigue severity scale, which can be instrumental in gauging the severity of the fatigue and also its impact on daily functioning. I carefully review the medications, checking for potential overuse or side effects of current medications that might contribute to fatigue. I carry out a sleep assessment, evaluating for sleep disorders, sleep hygiene, and sleep patterns. And I tend to carry out a psychological assessment, usually by using screening tools, but also do tend to screen for depression, anxiety, and other mood disorders. Let us now consider the management of fatigue in patients with headache disorders. The first consideration is lifestyle modifications. I engage in a discussion with them about physical activity. I make patients aware that regular physical activity and exercise has been associated with reduction in headache frequency and severity, as well as improvements in fatigue. Though it is important to be careful about the amount of exercise these patients are encouraged to undertake. It's important that they pace themselves carefully. I have a discussion with my patient about sleep hygiene. it's important to establish good sleep hygiene practices, such as maintaining a regular sleep schedule, creating a comfortable sleep environment, and practicing relaxation techniques before bedtime. I make them aware that this can lead to improvement in both sleep quality and fatigue, as well as lead to secondary benefits for their headache disorders. I ask my patients to carry out dietary modifications. I ask them to avoid any foods that are known to trigger their headaches, as well as maintaining a balanced diet and keeping themselves well hydrated. I also ask my patients to limit the intake of caffeine and alcohol as much as possible, as these are well known to contribute to headaches and also fatigue. The non-pharmacological interventions that can be considered are the behavioral therapies. There's very good evidence that cognitive behavior therapy, relaxation techniques, and biofeedback lead to a reduction in headache frequency and severity, as well as improvements in fatigue. Another consideration is acupuncture. There's evidence for benefit of acupuncture in patients with headache disorders, and there is some weak evidence that this also may be associated with improvement in fatigue. In terms of the pharmacological interventions, I first consider optimizing the headache treatments. I start my patients on acute and preventive treatments appropriate for the headache disorder. Improving the headache disorder is likely to lead to improvement of the fatigue. But in doing so, I tend to be careful about the use of treatments that may cause fatigue as a side effect. So the drugs that I tend to be careful about are the tricyclic antidepressants, the beta blockers, topiramate, pizotifen, and flunarizine. I tend to use drugs such as the GPANs, which are the CGRP antagonists, the CGRP monoclonal antibodies, and Botox injections preferentially, as their side effect profile is excellent, and these agents are less prone to causing fatigue. Another consideration is the nutraceuticals. Coenzyme Q10, riboflavin, and magnesium supplements can be beneficial for both headaches and fatigue, and I tend to use them preferentially whenever I can. The second pharmacological intervention to undertake is to treat the comorbid disorders. Where I can, I do address the sleep disorders using the appropriate treatments. For example, treatments such as melatonin or the appropriate antidepressants when sleep is associated with a mood disorder, using appropriate antidepressants to treat a mood disorder, which can then in turn lead to improvement of both the headache and fatigue. What is an open question is whether there is role for medications for fatigue. Modafinil, which has been used in narcolepsy, has shown promise in addressing fatigue in some patients, but there isn't an evidence base for its use in patients with headache disorders. Finally, let's move on to the future directions in research and clinical practice. I think we need further research into the pathophysiological mechanisms that underlie both fatigue and headache disorders. This will require investigating the broader relationship between the brain's pain and fatigue pathways, and also exploring novel therapeutic targets, especially at a molecular and genetic level. The other area in which I suspect that there will be advances are the technological and digital health aspect. Wearable technology, mobile apps, and telemedicine platforms offer novel avenues for monitoring, managing, and preventing both fatigue and headaches. These tools can track physiological parameters, symptom patterns, and even provide biofeedback or relaxation exercises, thus allowing for a more personalized approach to treatment. And I suspect that as time goes on, these will become more important tools for us to use. And finally, I think it's worth talking about the integrative and the holistic approaches that are necessary. Considering the multifactorial nature of fatigue and headache disorders, integrative approaches that combine both pharmacological treatments as well as physical therapies, besides psychological intervention and lifestyle modifications, need to be implemented. Such holistic strategies offer potential for more sustained symptom relief and improved overall well-being. And it's important to start emphasizing this to clinicians who are involved in looking after patients with headache disorders and fatigue. Thank you very much for listening to me.